Hi, everybody. Welcome to GW Center for Integrative Medicine and Dr. Kogan's Zoomcast. Yeah, you see me, I'm outside in the absolutely magnificent spring that's finally here. So I could not do that. It's not virtual background, it's our backyard. Um, so this is the second portion or part two of neuropathic pain. And actually we have decided we're going to have part three. So in this second part, I'm going to show you the other case that we have published a couple of years ago, actually in 2020. And the case is nicely summarizes the whole approach. It goes through a variety of different integrative approaches. I'm also going to walk you through the actual GW Center for Integrative Medicine treatment that went for this patient, just to give you a context of a very typical scenario that occurs in out there in the standard of care. So we'll cover all the topics except for one. You will see that this patient was recommended medical cannabis and she was taking, but because of the cannabis being so effective for neuropathic pain when applied appropriately, what we're going to do is we're going to actually have a whole dedicated part three that's dedicated just for medical cannabis, and Dr. Benavides and I will be covering that in the upcoming couple of days or a week or two. So with that, let's dive right in. As you remember, in the first part of the first video, we talked about the importance of addressing drivers. We talked about the value of identifying as many possible drivers and treating them. You remember that the case was the case of mercury toxicity in combination with a complex musculoskeletal dysregulation causing kind of a chronic severe neuropathic pain affecting several body parts. And then how we, in essence, cured this patient. And I'm not afraid of saying this word because in reality, when you say about neuropathic pain, traditionally thinking cure is not possible, but I disagree with that. We have over the years have seen patients whose neuropathic pain completely went away. And in the patient I presented, we did not do biopsies before and after, so we didn't have an actual tissue resolution, but we have a whole patient story, which you can look at the case that I put the link in. So in this part, let me walk you through the case because I do think that that would probably be the best. It would be the easiest to do it that way. I'm going to share my screen and we're going to jump right into the case. I do want to mention that Kimi and Avi are medical students at GW Center for Integrative Medicine in this case, and Dr. Chin is currently, as of now, retired, but she's one of the senior physician at the Chronic Pain Center at GW Medical Faculty Associates. So this was the case. The woman at presentation was 71 years old. She had a complex pain syndrome. In addition to chronic neuropathic pain, she had degenerative arthritis, restless leg syndrome, carpal tunnel syndrome, and quite a severe and very long-lasting anxiety. I think one way I'm going to start with the case is right here. So those of you who've been following my work know that I'm a huge stickler for the timeline to understand and correctly treat patient, timeline of appearance of symptoms, as well as what treatments were done and in what sequence before is generally most important aspect of establishing appropriate path for patient to get better. So in this situation, you see that the date of the assessment went back to 2007 when patient was first diagnosed with a bilateral mild sensory neuropathy by MRI and by EMG, so the nerve conduction study. And as you can see on MRI, a little later, it was shown that she had a pretty significant spinal stenosis with moderate right pericentral disc protrusion and compressions of at least one nerve root. So she was presenting, in addition to that, at that time, she basically went through a standard allopathic model. She was sent to, in addition to neurology, of course, she was sent to the spinal orthopedics. She was tried on multiple different medications. Here's the list: ropinirole, gabapentin, pregabalin, NSAID, Tylenol with codeine, physical therapy, and all of those were unsuccessful. She was at that point offered injections as well as X-stop, which is a orthopedic procedure. And she really chose not to do that after considerable amount of back and forth. Now, I do want to put disclaimer here that this has all happened before patients came to see us. So she had a follow-up MRI in 2013 that basically showed that, not much really changed. So the MRI between 2007 and 13 was roughly the same, maybe somewhat progressive. So we started treating her in March 2018. And when we first assessed her, we did notice that she had a borderline low B12. I do want to point out one important aspect, that while this patient, as you will see, have obtained number of integrative approaches, her initial evaluation, assessment, and treatment were done through the Medicare clinic covered by insurance. And some of the steps here were all through the relative standard of care. Once she started deviating into things like acupuncture, massage, and yoga, I'll bring that up in a second, but that's, of course, for her was out of pocket. And in 2018, acupuncture for low back was not approved yet. So we did give her a methyl B12 injections, as well as methyl B12 and methyl folate sublingual. She, at that time, was tried by another physician of dronabinol. Actually, I think she was already given that script. She was reluctant to try it. And we've discussed it, and she wanted to go ahead and try it because she already had a prescription. So she went and go ahead, and dronabinol is a synthetic pure THC, tetrahydrocannabinol, which is the synthetic cannabinoid, which it's not FDA approved for chronic pain. It's used sometimes for chronic pain with I would say very marginal successes. And this patient will definitely concur with that. She felt that it caused more side effects than any benefit, and she was not continuing. And again, as I said, we will dedicate the whole talk to the cannabis. So you can see that this patient also was given magnesium, fish oil, and the Tylenol with codeine was continued as needed. So we are in spring of 2018. Around same time, she was suggested to begin to attempt to do acupuncture, massage, and gentle yoga. And that's what she was doing. So on a follow-up, which was about 6 months after the initial presentation, patient stated that she felt somewhat better, that she wanted at that point address some of her chronic anxiety, weakness, and fatigue. At that time, we discontinued one of her medications because her blood pressure seemingly was stable and her heart rate was reasonably good. And we started her on a low dose of CBD. In following few months, so this is just before the COVID, patients continuous reported further improvement. She had significantly decreased acetaminophen with codeine. Before that, she was using it almost daily. At that point, somewhere between October and January, she basically started using a Tylenol with codeine once or twice a week at the most. Around the same time, we also gave her a medical cannabis recommendation. She actually obtained it, I believe, a little bit later. So yeah, so in the actual protocol, a formal recommended protocol was initiated to her in June 2019. When we talk in this part 3, we will bring this case back up and discuss specifics of what form and how it was used. So she continued with massage and acupuncture and yoga. So just want to skip going forward. So the 2019 came and went, and this is where she came to the clinic with a significant worsening of her situation, because in April 2020, she was no longer able to continue massage, acupuncture, and yoga classes because everything got shut down from COVID. So she started asking for more Tylenol with codeine. What's interesting to report is that approximately 3 months later, our clinic have started a comprehensive, ongoing, weekly Zoom-based mind-body shared medical group, which this patient participated in. And through that, she sort of went back to her pre-baseline to reasonably good functioning with very little use of Tylenol with codeine, because the modalities, yoga, have helped her significantly in combination with supplements and B12 injections. So let's summarize this. In essence, and by the way, this is the full detailed analysis of everything she was taking. It's all in the case. It will all be in the links to this video. So you will be able to look at all of this. So it's a pretty typical management strategy. It's a kind of a combination of some body work, particularly acupuncture, if it's a low back pain, is highly evidenced, and Medicare has approved it in 2019, as I mentioned it. Massage can be very effective, especially if the anxiety severely exacerbates the pain. And also, massage can be very effective if the patient carries a lot of spasms and a lot of tension in the body. Massage can be quite effective. As you see, also the personal practice of a physical activity that will maintain muscle strength and stretching and is quite important, and as well as managing her anxiety. And I will say that probably 30 to 50% efficacy, a total amount of improvement in this patient was due to the combination of different cannabinoids, which she is still, now we are 3 years later, she's still taking that. And I'm seeing her on a regular basis. In fact, I just refilled her medical cannabis, re-signed her medical cannabis card a few days prior. So drivers, once you figure the drivers, you try to address them. That was the case that I showed you on the first video. This video has a little bit less of that. Yes, you can try to mechanically correct spinal stenotic lesions, and for example, put, like the X stop was brought up, it's a type of orthopedic procedure. You can do surgery, you can do injections. The thing is, though, I just want to put a caution for those listeners who are seriously considering orthopedic steps. The problem with the orthopedic attempt at correcting variety of different issues is this. First of all, they're never guaranteed that the result is going to be a correction of pain. And the problem is that pain often is a lot more complex entity than simply saying, oh, there's a compression, let's fix it, pain will go away. It's a lot more complicated than that most of the time. Second of all, when you're looking at MRI, it's very hard to predict based on the way MRI looks, someone would have a pain or not. You can have two exactly same looking lesions on MRI, and one person is going to be completely pain-free and one is going to be in an excruciating pain. And you have to ask, well, why is that? Well, because the problem is that the thresholds for pain are different, functional states are different. Pain is not all about how much the nerve is compressed. It's in itself, the pain as subjective feeling is more complicated. Like somebody with anxiety more likely to have more pain than somebody who does not have anxiety. So there's a lot goes into it. So that's very important to realize. And I think that's why we did very well with this patient, is that she herself was very clear she's not going to pursue any orthopedic interventions, not only because she was really honestly scared of them. She herself believed that she will be able to manage her problem without severe interventions or aggressive interventions. So that's also quite important. I mean, we do often get patients after they went through the full orthopedic route, they had a surgery, they had some procedures, and they still have pain, and then they come to us. Unfortunately, often that leads to their pain being also, in addition, having now a severe mechanical limitation through which it's a bit harder to work. We generally say, give us as much time as you can give us to try to put this comprehensive integrative approach before we have you go see a more aggressive intervention. Now, this is, of course, case of partial spinal stenosis. So I would say that it's a little different from lots of other types of peripheral neuropathy where orthopedic approach would not even be considered because it wouldn't be considered appropriate. For those patients, as I mentioned, after the drivers are treated, you really need to try to continuously optimize the protocol. What I often find is most of the patients will plateau pretty quickly. Within 3 months or so of application of a first approach, they're going to reach a certain steady state. So they'll get 50% better, for example, but they will not keep getting better and better. That's when we add additional treatments typically. So what you haven't seen us discuss in this video are a number of things. So for example, low dose naltrexone, we use it with a very high percent of patients. Additional more aggressive manipulation. So whether they're going to be an osteopathic manipulation, such as craniosacral approach or direct force application, or even a chiropractic or more chiropractic-like, so more high velocity application of force. Definitely more movement treatments. Alexander technique is huge. If patient has neuropathic pain in combination with, let's say, a back pain or a neck pain, and the part of the neuropathic pain is definitely associated with some structural, anatomical, postural problems, then of course Alexander technique would be probably top of my list. Probably even before I would recommend acupuncture, to be honest, or at the same time. Of course, as I said, cannabinoids is a separate topic, but there are a whole lot of other supplements that I often use. I like to try omega-6 fatty acids, gamma-linolenic acid from evening primrose or borage oil. I definitely like to use homeopathy with certain patients with certain types of symptoms. We now have a constitutional homeopath in our practice. Sometimes I would refer patients to her for that. I definitely found that some patients will benefit from that. I used to be quite afraid of sharing this in public, but I'm not anymore because I have seen some success stories that define any explanation. And yes, there is no evidence for that in the controlled settings, in the randomized control settings, but I think anybody who's been long enough in practice have seen stories and seen cases. Of course, low-level lasers of different sorts, red light, magnets, all those things can be very helpful. We apply them in different situations. I usually don't put any of them as a first line because those are additional costs. Some of those things require adaptation of certain technology to a certain level, and if the patient is not just necessarily not computer savvy, they may not want to get an additional piece of equipment to be with them for a while, but sometimes those things are very effective. And of course, physical therapy is a main line, not necessarily to cure the pain or get pain a lot better, but to really return functionality. And sometimes when patients get more functional, more active, that in itself will at some point have a better pain scores eventually. So I'm sure I'm missing some things. I didn't make a list, comprehensive, like complete list, because it would be a lot of information to give. There are also a lot of other supplements that I didn't really want to go into huge detail on for a variety of reasons, but they are there. If anybody is interested, I can also recommend, if you're more inclined with a much more medical way of assessing this, the chapter in my Integrative Geriatric Medicine textbook on pain has a whole section on neuropathic pain, and I'll if needed, I'll put the link in the YouTube video to the book if anybody cares about reading a much more to the practitioner level of evidence-based and complexity of care. Well, I hope you have a wonderful rest of the day, and stay tuned to more videos on what's up to date in integrative medicine, how we manage certain conditions, and anything else that is interesting and important for your health and wellness. Stay tuned. Bye-bye.